Hello, my dear curious and studious students of surgery. Myself, Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome, my dear students, in my surgery lecture number 61, that is the carcinoma of the prostate. In this lecture, we will cover the etiology of the carcinoma of the prostate, spreads of the carcinoma of the prostate, types of the carcinoma of the prostate, difference between the benign enlargement of the prostate, benign hyperplasia of the prostate and carcinoma of the prostate, clinical staging, investigations and the treatment of the carcinoma of the prostate. Now start with me the carcinoma of the prostate. Carcinoma of prostate is the fourth most common cause of death from malignant disease in men. It is the commonest malignant condition in men over the age of 60 years. It increases in frequency thereafter, probably afflicting 25% of men in the 8th decade. In the series of the autopsies in men over 80 years of age, 2/3 had prostatic cancer. Now the etiology. The disease is rare in Orientals but more common in blacks. Estrogen therapy or orchidectomy shows down the growth of these tumors and maintain the amount of acid phosphatase in the blood at the normal level. Determination of the amount of acid phosphatase in the serum is therefore an index of the presence of aggressiveness of the tumors. Now pathology. First we see the microscopic features. When the tumor is anaplastic, the diagnosis is easy, but when it is differentiated, it is difficult to distinguish this lesion from the benign hyperplasia. Confluence of acid infiltration of the stroma, the perineural lymphatics and the capsules are the characteristic features of this condition. Now dear students, here is a good image on your screen that is showing the carcinoma of the prostate. There is a tumor in the prostate, you can see clearly in the white patches. This is the second image showing the localized prostate cancer in the prostatic capsule in the prostate gland, and this is the third image showing the carcinoma of the prostate according to its stage, that is the T1, T2 and T3. The size of the carcinoma of the prostate is respectively increases. Now the next point is the spread of the carcinoma of the prostate. First is the local spread. Growth commences as a rule in the posterior lobe. By direct spread, it gradually involves the lateral lobe. It cannot extend backward due to the presence of strong fascia of Denovilliers. Second is the second route of the spread of carcinoma of the prostate are lymphatic spread. Lymphatic spread occurs by either permeation or embolism. And third is the blood spread. Spread to distant parts may occur through the bloodstream. Cancer prostate is the most common site of the primary neoplasm for skeletal metastasis, which is followed by the cancer of the breast. The tumor's embolus penetrates into the periprostatic venous plexus. From here, the tumor cells pass along the vertebral system of veins. During coughing or sneezing, only occasionally the transitional cell carcinoma of the prostate may produce osteolytic bone metastasis. Lung and liver metastases are rare in prostatic cancer due to spread by bloodstream, that is not lymphatic. Now the clinical features. The single main presenting symptom peculiar to cancer of the prostate is obstruction to flow of urine causing acute and chronic retention of the urine. A cancer prostate may present in various types. Type 1, 2, 3 and 4. Type 1, occult type, which means that at the time of routine histological examination of the tissue removed by the prostatectomy shows presence of carcinoma. Type 2, the patient presents with symptoms of prostatism. Type 3 is the patient presents with acute and chronic retention. On rectal examination, hard consistency and irregular surface in the prostate are felt to the finger. Type 4 is the symptom due to the metastasis. 1 out of 20 patients may have their first symptoms from metastasis. Now the physical sign. Rectal examination is by far the most important examination for the diagnosis of cancer prostate. Here is the image you can see on your screen, dear students. There is the type of the pathology, frequency and percentage. The adenoma of the carcinoma of the prostate is 75, that is the percent is 75. Intestinal cell carcinoma is 4, neuroendocarcinoma 0, sarcoma 1, HGPIN 0 and LGPIN 0. Now the difference between the benign hyperplasia of the prostate and the carcinoma of the prostate are, according to size. In the benign hyperplasia of the prostate, the size may be quite big, but in the carcinoma of the prostate, the size is usually not very big. In the consistency, in BEP, benign enlargement of the prostate, it is firm and elastic, where in the carcinoma, it is hard. And according to the surface, in the BEP, that the prostate gland is feeling the smooth, where in the carcinoma of the prostate, that is the irregular and nodular. The middle circle between the two lateral lobes is well felt in the benign hyperplasia of the prostate, where the sulcus is usually obliterated in the carcinoma of the prostate. The seminal vesicles feels normal in benign hyperplasia of the prostate, where in the carcinoma of the prostate, these may be invaded by the tumors and feel hard and irregular. The gap between the enlarged prostate and the lateral pelvic wall is clear on both sides in the hyperplasia of the prostate, where this gap is obliterated by the invasion of the cancer in the carcinoma of the prostate. In the benign hyperplasia of the prostate, the rectal mucous membrane moves free over the enlarged prostate, where the rectal mucous membrane is adherent to the and cannot be moved over the prostate in the carcinoma of the prostate. Now, the clinical staging. By manual examination under anesthesia, one can clearly assess the extent of the tumors. That is the TNM system of the classification as revised in 1974. The various clinical examination and special investigations which are performed to clinically stage the tumor and its metastases are as follows. T categories: clinical examination, urography, endoscopy and biopsy. N categories: clinical examination, lymphography and or urography. And M categories: clinical examination, chest X-ray, bone scan and determination of the acid phosphatase level. First, we start with the T primary tumors. T0, no tumor palpable. This category includes those cases of the incidental findings of cancer in an operative or biopsy specimen. T1 is the tumor is intracapsular surrounded by the probably normal gland. T2, tumor is confined to the gland. Smooth nodule may deform the contour, but the lateral sulci and or seminal vesicle are not involved. T3, the tumor has extended beyond the capsule with or without involvement of the lateral sulci and or seminal vesicles. T4, the tumor is fixed and had invaded the neighboring structures. Now here is the image on your screen is clearly showing the prostate cancer stages. Stage 1, the cancer is small and only in the prostate. Stage 2, the cancer is the larger and may be in the both lobes of the prostate but is still confined to the prostate. And stage 3 of the prostate of the cancer has spread beyond the prostate to close by the lymph glands or seminal vesicles. Stage 4, the cancer has spread to other organs such as the bone and is referred to as metastatic cancer. If prostate cancer spreads on metastasis to the bone, you have prostate cancer cells in the bone, not bone cancer. The prostate cancer in the bone, and that is not the bone cancer. Always remember this. Now here is a good diagram showing the stages of the carcinoma of the prostate. Stage 1, the carcinomatous tumor size is small, where the stage 2, the tumor size is increased. Stage 3, that is the invaded the external capsule of the prostate, and stage 4, it is the occurring the neighboring organs in the stage 4. This is the same image showing the same stages. You can watch this. Now N regional lymph nodes. N0, no evidence of involvement of regional lymph nodes. N1, involvement of a single regional lymph nodes. N2, involvement of multiple regional lymph nodes. N3, fixed mass of regional lymph nodes. N4, involvement of juxta regional lymph nodes which are common iliac or para-aortic nodes. M, distant metastasis. M0, no evidence of distant metastasis. M1, distant metastasis present. M1A, evidence of occult metastasis detected by the biochemical and other tests. M1B, evidence of single metastasis in a single organ. M1C, that is the multiple metastasis in a single organ. And M1D, that is the multiple metastasis in the multiple organs. Dear students, here is the text image. You can see as we show, that is the T0 is the evidence of primary cancer. T1 is the tumor nodule in the palpable normal glands. T2 is the smooth nodule which deforms the contour of the gland. And T3, the tumor has extended beyond the capsule and has invaded the seminal vesicles, where the T4 is the tumor is fixed or has invaded the neighboring structures. Now special investigations: blood examination, urine analysis, liver function test should be performed to exclude any metastasis in the liver. 4th is the straight X-ray of the abdomen. 5th is the axillary urography, chest film, chest X-ray, ultrasonography. Transrectal ultrasonography is now often used particularly in screening to detect the early carcinoma of the prostate. And 8th number of the investigation is the magnetic resonance imaging, that is the MRI. This investigation is being used mainly in specialized centers for staging of prostatic cancer. CT is almost incapable in staging prostatic tumors unless the disease is grossly advanced. Another important application of MRI is prostatic cancer is the diagnosis of spinal cord compression due to the metastatic bone involvement MRI shows. And next is the bone scan. This is much more effective than simple straight X-ray. This is performed by injection of 99 technetium and the isotope is then monitored using a gamma camera. The isotopes will conglomerate in an area of increased blood flow producing hot areas. Lymphangiography. This procedure is increasingly used to seek evidence of metastasis to the pelvic nodes. Biopsy. Prostatic biopsy, a needle biopsy specimen taken from the posterior aspects of the gland through the perineum, is more reliable than obtained transurethral. Next investigation is the aspiration of bone marrow. Posterior iliac crest may show malignant cells in the bone marrow. Tumor markers, serum acid phosphatase is normal. The serum alkaline phosphate is also elevated in the patients with metastasis in bone. Now the prostatic specimen antigen, that is the PSA, serum PSA. This is the most important tumor marker now available to say that if PSA is more than 10 nmol per ml, it is suggestive of a case of the prostatic cancer. If the PSA is more than 35 nmol per ml, it is a case of the advanced prostatic cancer. Now the treatment of the carcinoma of the prostate are, carcinoma of the prostate should be treated accordingly to the stage of the disease or pathological types of the tumors. Latent carcinoma, that is the T0, N0, M0, that is the stage first. In this group there is no evidence of tumor on clinical examinations, but carcinoma is detected histologically usually in the tissues removed by the prostatectomy. Second is the carcinoma confined to the prostate, that is the T1 to T2, N0 to N1 and M0, that is the stage second. This group includes small nodule T1 and large tumor deforming the contour of the prostate but are still confined with the capsule T2. There are various options to treat this case. For this, the radical prostatectomy or radical radiotherapy or endocrine therapy should be given. Radical excision, radical perineal prostatectomy is often used in USA. Radical radiotherapy, 7,000 rads of radiation was given to the prostate and 5,000 rads to the pelvis using a sandwich technique. And third is the endocrine therapy. Locally advanced disease, that is the T3 to T4, N0 to N1 and M0, that is the stage 3. Between 1/3 and 1/2 of the patients presenting with the prostatic cancer have locally extensive disease with no evidence of distant metastasis. 50% of these patients are expected to have lymph node metastasis. The result of radical prostatectomy are poor in this group of the patients. External beam radiation therapy should ensure a more satisfactory. This group should be treated by endocrine therapy. Preliminary endocrine treatment has been tried. Now disseminated disease, that is the T3 to T4, N0 to N1 and M1, that is the stage 4. Between 1/3 and 1/2 of the patients with prostatic cancer have metastasis at the time of presentation. Hormonal therapy is the best in these cases. These are treated with stilbestrol 5 mg per day. Then the next stage of the treatment in the carcinoma of the prostate are orchidectomy. Charles Huggins in 1941 showed that the bilateral orchidectomy can be performed for androgen ablation in prostatic cancer. He received Nobel Prize for this. Nowadays, subcapsular bilateral orchidectomy is performed as an alternative or an adjunct to the stilbestrol therapy. Chemotherapy. A few cytotoxic drugs have been identified which show some activity against the prostatic cancer. These are adriamycin, cisplatinum, cyclophosphamide and 5-fluorouracil. Radical perineal prostatectomy. Now the open surgery, radical perineal prostatectomy. The initial steps of this operation up to the exposure of the prostate are more or less similar to those of the perineal prostatectomy has been described previously in our lectures. The entire prostate with its facial sheath and the seminal vesicles is removed in one piece. The nearby lymph node should be dissected and included in the removal of the prostate. The vesical outlet is now united to the membranous urethra over an indwelling catheter. The perineal wound is closed around the free drainage. Now the next point of this lecture is the prostatitis. Infection usually involves three structures simultaneously: the prostatic urethra, the prostate and the seminal vesicles, which lead to posterior urethritis, prostatitis and the seminal vesiculitis. Symptoms of one of these may dominate. Dear students, here is the end of our surgery lecture number 61, that is the carcinoma of the prostate. Thank you.